It's Thursday, April 3rd, 2025, and welcome back to Matters of Policy and Politics, a Hoover Institution podcast devoted to governance and balance of power here in America and around the globe. I'm Bill Whalen. I'm the Virginia Hobbs Carpenter Distinguished Policy Fellow in Journalism here at the Hoover Institution. I'll be moderating today's conversation. I'm not the only Hoover Fellow who does podcasts, though, and I recommend you go to our website, which is hoover.org. Go to this link in particular, hoover.org/podcasts. There you'll find audio podcasts, video series, all kinds of stuff we're doing. So today we're going to talk a bit about an anniversary that went by unnoticed in March, and that was the 15th anniversary of the signing of the Affordable Care Act, March 23rd, 2010, the actual date when Barack Obama put pen to paper and signed the ACA. And, well, it changed public policy and it also changed politics. I remember that once he signed that bill, we thought, my goodness, how long before a Republican president comes along or the Republican Congress and they do away with Obamacare, but here we are 15 years later, and Obamacare is quite alive and ticking. What's also curious, the reason why I wanted to do this podcast today is because the Trump administration has been in power for about 74, 75 days now, I believe. Haven't heard much about healthcare. Now, maybe that's just a reflection of Donald Trump is making news every day. Elon Musk is in the news every day. We're getting overwhelmed by DOGE and layoffs in federal workforce. And of course, today, the world exploding over tariffs. So maybe just not a lot of bandwidth for healthcare. But helping me make sense of this and more matters on healthcare today is my colleague, Lanhee Chen. Lanhee Chen is the David and Diane Steffy Fellow in American Public Policy Studies here at the Hoover Institution. He also co-chairs Hoover's Healthcare Policy Work Group. Lanhee was also policy director for the Romney-Ryan presidential campaign back in 2012, his job coming up with positions on matters like healthcare. Lanhee Chen might be familiar to a lot of you in California because if you got a ballot in 22, there he was on the ballot as a candidate for Republican state controller. He holds the distinction of being the Republican candidate and gets the most votes in America in 2022, by the way. Lanhee, thanks for coming on the podcast.
Hey, Bill, great to be with you. Thank you.
So, question for you, my friend. Where were you in March of 2010?
March of 2010, I was working for a guy called Steve Poizner.
Yes.
And he was running for governor of California.
Yes.
And that was before the primary election when he lost. I think the primary was in June. So I was in Sacramento at the time.
Okay. Steve Poizner, by the way, is an interesting trivia question. The only Republican other than Arnold Schwarzenegger to win a statewide office in California in the last, 30, 35 years.
Yeah.
2010, Lanhee, was quite a colorful year, eventful year in American politics. It began in January of 2010, you might recall, when there was a special election in Massachusetts. This was to replace Ted Kennedy, who had passed away. And the election produced a shocker in that the Republican candidate, Scott Brown, won that election. I went back and did some sleuthing, Lanhee. I looked at the exit polls. 52% of Massachusetts voters said they opposed the idea of ACA at the time. It had not been signed yet by Obama, but not for a couple months. 42% of voters who voted for Brown said they voted for him for that express purpose to make sure that ACA never happened. Then, of course, Obamacare happens. We have an election in 2010. It's a wipeout for Democrats. 63 House Democrats are tossed out, Lanhee, including, according to one study I saw by pair of political scientists, 13 House Democrats lost their jobs due to their vote on Obamacare. We continue on with this. I was looking at NBC Wall Street Journal polls, for example, the Affordable Care Act underwater from 2010 to 2017. And then in 2017, something kind of interesting happens, Lanhee. It suddenly becomes a lot more popular. And maybe that coincides with Donald Trump coming to office. So here's my question to you, Lanhee. Once Obamacare was signed into law, was it always going to be here, or did Obamacare get a new lease on life on July 27th, 2017, when John McCain came back to Washington and famously cast the no vote on the skinny reform?
I think the reality, Bill, is that the longer a piece of public policy, particularly one that has been through the legislative process in the way that the Affordable Care Act was, the longer you have a law in place, the harder it is to get rid of it. I mean, that's just the reality. So to the degree that there was an opportunity to repeal the law, it would have been, right around 2012 when I was working, as you noted, as the policy director of the Romney-Ryan campaign. I mean, one of the things that we spent a lot of time on was, what was the mechanism to effectuate repeal of the law and what would a replacement looked like, more importantly. What elements of the law needed to be fixed, which ones needed to be completely replaced. And that was a lot of hard work with a lot of people went into that, many of whom have gone on to serve in a Republican administration. Some of them are serving in government now. So I think the opportunity would have been there, but once you got to 2017 and once it became as polarized as it did, the likelihood that anything was going to happen to it in a really substantial way, I think, was pretty small. And then the other issue, of course, you run into is that over time, people get used to it. They get used to the elements of it. There are things about it that become politically more salient, like, for example, the restriction the law puts on denying coverage based on pre-existing conditions. That was the core center of the debate in 2017. People didn't want to get rid of that, right? So the law, once it's there for a while, is popular, and then elements of it become even more popular, and it turns the popularity of the whole law. Where if you were to look at survey research today, you would find that, about 60 or 65% of Americans like the ACA. Here we are 15 years down the road, and the public opinion on it has essentially completely flipped from when it was first passed.
So I'm going to read you a quote, Lanhee, from what Donald Trump said in his lone debate with Kamala Harris last year. Quote, Obamacare was lousy health care, always was. It's not very good today. And what I said that if we come up with something and we are working on things, we're going to do it and we're going to replace it. Now let's fast forward to him being back in office as a 47th president. He has done something on healthcare. He signed an executive order dealing with healthcare pricing transparency, and it does relate to Obamacare in this regard. It messes with the enrollment period for Obamacare, takes it back by a month instead of from November 1st to December 15th. It's now November 1st, December 15th instead of the January 15th deadline. So he's tinkered with it, but boy, that's not repeal or replace, is it?
Yeah, I mean, I think it speaks to the reality of
Right.
how hard it is to do anything really fundamental to the law. I mean, I think the administration is going to do some things that are helpful to the healthcare system, like, for example, promoting more transparency around pricing, which is something they did in the first term. Again, not directly related to Obamacare, but I think good for the healthcare system. But the likelihood that they'll be able to really kind of do much about changing the arc of the law, pretty low likelihood. And again, it gets back to how hard it is to change something as entrenched as the ACA.
Right. Let's talk about Washington, what Washington can be doing on healthcare, Lanhee. Actually, first, let me ask you this question. So you're doing American public policy studies. That's a pretty big umbrella. How did you end up with healthcare reform?
Well, a lot of my initial policy work when I first started in public policy was in healthcare, and part of it was influenced by my dad, who's a medical doctor, and so I had a lot of exposure to the healthcare system when I was younger, and had an interest in it. It's a pretty complicated area of policy. I mean, I think all public policy has its own
Right.
little twists and turns, but I think healthcare has a complexity to it. And I really took to that when I first did policy work. And then when I served in government during the Bush administration, George W. Bush administration, that's the agency I worked in, the Department of Health and Human Services. So got a view in government, got a view outside of government. And so for me, at least, it's just been an area of policy that I find fascinating, and have spent a lot of time and energy over the years focused on it. So, that's the story.
So you wrote a column recently with your colleagues Tom Church and Danny Heil, the title which 15 years later, the ACA has an HSA problem, and you can explain HSA to us, health savings accounts. It's interesting. So you mentioned the polling on Obamacare, Lanhee. It's about a 60-40 split,
Yeah.
62-37 or so. It drops a couple points if you call it Obamacare instead of the ACA, but it's
Yeah.
more popular than it's unpopular. But yet there's a question of product demand. And what you point out in the column is this. You note that the Congressional Budget Office back in 2010 predicted that there'd be 24 million Americans buying insurance on exchanges by 2019. But if you look at the actual numbers, it turns out to be 10.6 million. You also predict enrollment will be declining this year. So if the product is popular, Lanhee, why don't we see it reflected in the numbers of people signing up?
Well, because I think fundamentally the product that's being offered is not a great fit for what people want.
Mhm.
People want to be able to choose healthcare coverage product that makes sense for their lives, that is adaptable, that's flexible, not one that's relatively rigid. Generally speaking, fairly fulsome in benefits and pretty high in cost, right? And I think that's the explanation. If you look at the coverage gains that have come through the Affordable Care Act over the last 15 years, the vast, vast majority, by some measure, over 80% of the coverage gains have not come from private health insurance. They've come from an expansion of a program called Medicaid, which in California we call Medi-Cal. But fundamentally, what Medicaid is it's coverage for lower income Americans. This is government run coverage. And there's been research about whether coverage under Medicaid is any more effective or efficient at promoting health outcomes than having no insurance at all. Now, I think it's hard to make that case, but the reality is that Medicaid is a program that is riddled with a lot of challenges. And so the idea you're speaking about, which is private health insurance offered through marketplaces, which was definitely a part of the Affordable Care Act, it
Mhm.
hasn't been as popular as I think the Congressional Budget Office originally thought it would be, or people who originally advocated for the law thought it would be, because the insurance offered through it is expensive and it doesn't fit what most people want. And so part of the answer there is, can we create a system that offers a little bit more choice, a little bit more variance in terms of pricing, so that people can get access to plans that maybe suit them better at a price that works, and is free of some of the bells and whistles that a lot of these plans have on the
Right.
Obamacare marketplaces. I think that's really the fundamental issue.
Let's look at three matters being discussed right now, Lonnie, and you tell me what the significance is. The first one, how does healthcare relate to the upcoming conversation on tax reform?
Well, it's a significant relationship because a lot of what drives healthcare policy is tax policy. The
Right.
single biggest element of why we have the healthcare system we have is because of a provision in the tax code that says that if you get your health insurance through your employer, that insurance as a benefit is not taxable to the employee and is a write-off, is a tax deduction for the employer. And so that interpretation of the tax code drives so much of not just tax policy, but healthcare policy in this country. So when we have a discussion around healthcare reform, it's going to be a conversation around tax reform and vice versa. So very close relationship. When they look at changes to the tax code, there will almost certainly have to be impacts on healthcare in some way. Healthcare is 20% of the economy. It's highly unlikely that you wouldn't find the tax code change to impact healthcare in the country.
We're talking about they as in Congress, but are you looking at a he or she, Lanhee, someone like a Bill Cassidy who's going to be leading this?
Yeah, I mean, this is a process that's going to be driven by members of Congress in the majority party. In the House, it's the Republicans. In the Senate, it's the Republicans. So, yes, Senator Bill Cassidy of Louisiana is a great leader on healthcare issues, a guy who knows a ton about these issues and cares deeply. On the House side, you're going to have Jason Smith, who's the chair of the House Ways and Means Committee, the principal tax writing committee there. They're going to be very, very engaged as well. So it is going to be a conversation for congressional leaders as they figure out how to put together, as President Trump says, one big, beautiful bill. And when he talks about that, part of that is whether these tax changes go into that bill. Now, there's some skepticism about whether the one bill can contain all of this stuff, but
Right.
we're going to see some significant legislative activity as we get into the summer and fall months of this year.
Okay, item number two, Lonnie, Medicare.
Mm.
Medicare expenditures in particular, copying from your column, 2.2% of GDP in 2000 Medicare expenditures, 3.7% in 2023, projections showing it going up to 5% by 2034. And now, when we talk Medicare and entitlements, Washington likes to kick the can down the road, doesn't it?
Yeah, and the reason why we're seeing a higher percentage of GDP spend around Medicare is twofold. One is we have more and more people who qualify for Medicare because we have an aging population and a lot of the boomers are retiring and
Right.
of Medicare age. But the second reason is because healthcare is becoming ever more expensive. So if you look at healthcare inflation, those percentages tend to outpace core inflation or inflation in other parts of the economy. And
Right.
so healthcare expenses are rising, consumption is rising, and as a result, total Medicare expenditures are rising. And that's a trend that we don't see, abating anytime soon. So
Yeah.
the question will be when policymakers decide they want to make Medicare more fiscally sustainable. And as you know, politically, I think that's a very challenging topic.
Okay, and item number three, Lonnie, telehealth expansions. Now, I don't know much about telehealth, but I do know it has to do with distance health, so I start thinking red states.
Well, it's great for rural areas where
Yeah.
you don't have ready access to healthcare facilities, but telehealth essentially is, getting access to healthcare, whether a doctor, registered nurse, whoever can help diagnose a health condition
Right.
via technology, right? Well, whether it's a mobile phone or Zoom call, whatever it might be. And that's something that really was a big element of healthcare during the pandemic and right after when people weren't engaging in as much in-person activity.
Right.
And for some Americans, that access is really, really important. And so we want to figure out ways to continue to incentivize the adoption and the continuation of telehealth. And those authorities Some of those which were originally created during the pandemic have lapsed or will lapse. And
Mhm.
so we want to create a permanent way of getting access to healthcare in that way.
What did COVID teach us, Lanhee, about both the promise and challenges in doing telehealth?
Well, the promise is access.
Mhm.
You get people who are able to see a doctor usually much more quickly, and they don't have to travel hours in some cases to see a doctor. Now,
Right,
the restriction, the challenge is that there's only so much we can do remotely, right? I
right.
mean, there's only so much diagnosis we can do without actually, in some cases, having physical access to a patient, being able to draw blood, being able to take specimens, things that are needed to diagnose disorders, diseases, conditions. It's very hard to do all of it. I think there are certain kinds of healthcare that are well suited to telehealth. Certain dermatological conditions, mental health, behavioral health issues. Those are things that I think can be handled reasonably well via telehealth, but it's not for everything. And so we
Mhm.
have to continue to be mindful of the fact that we need a system that allows for broad access and people to be able to seek care, notwithstanding the fact that they may live some distance from a doctor.
So, healthcare reform was discussed by Congress last year. It was formerly the 482-page bipartisan Healthcare Act. It included telehealth extensions, as you've been talking about. It included pharmacy benefit manager reform. It addressed the opioid crisis. It didn't go anywhere, Lonnie. And this is what has me curious about healthcare reform in Congress. 2024 is an election year, so maybe it just died because of election year politics. 2026 will be an election year. 2027, if the Democrats pick up the House, is a divided Congress, so it becomes all the more problematic. Then you're to 2028, another presidential election year. So does that kind of make, in some regards, 2025 is kind of a year by default to get things done?
Yeah, I mean, I do think if we're going to accomplish anything on healthcare, it's going to have to
Yeah.
be this year. It's probably going to be part of the one of the legislative couple of legislative packages we see this year. Highly, highly unlikely that it happens in an election year, A, because it's complex, but B,
Right.
I think a lot of members of Congress don't like to deal with healthcare. I think,
Right.
their view is, look, we did Obamacare, we did a couple of other big pieces of healthcare legislation over the last 15 years.
Mhm.
Why do we need to revisit this again, right? And so
Right.
every year there are a few healthcare provisions that have to get dealt with because if they don't, doctors don't get paid and things don't happen. So we deal with those. But aside from that, the reality is that there's not a tremendous amount of demand amongst members of Congress or frankly amongst presidents to deal with these issues. So I think your assessment of the calendar is right. This is going to be the
Mhm.
year to get things done, and we'll see if it happens.
All right, let's shift for a moment to California now. Let's talk about what's going on in Sacramento. It has a real budget problem with Medi-Cal. California is the first state to offer government health care to all low-income people. Medi-Cal is the state version of Medicaid. It's the first to offer, as I mentioned, health care to low-income people, regardless of immigrant status. About 1.5 million immigrants without legal status are enrolled now in Medi-Cal, but California cannot afford it right now. You've also seen, Lanhee, a spike in seniors applying to Medi-Cal, about a 40% increase. And you referenced this earlier in terms of the cost. I looked up the numbers here. It costs California on average about $15,000 per senior enrolled in Medi-Cal versus about $8,000 for non-seniors. So what's Sacramento going to do here, Lonnie? Because you have the fiscal reality of having to balance a budget. California has to balance a budget, unlike Washington. Now we can get into smoke and mirrors if you want to, but you also have a governor with presidential ambitions who has been in the last month or so trying to show a little leg, suggesting that maybe he's a little more moderate than you think. And you have this hot button issue of undocumented Californians getting public benefits. So, your thoughts on how this gets resolved?
Well, it's the same way it gets resolved every year, which is
Yeah,
that they end up kind of reducing the amount that they pay physicians to see patients. And
right.
and and so if you look at the broad spectrum of how healthcare providers get paid, if they see a patient through commercial insurance, the insurance you get through your employer, let's
Right.
assume for a moment that the provider gets paid $1.
Mhm.
If they're seeing a Medicaid patient, a Medicare patient, excuse me, this is the old age program. If they're seeing a Medicare patient, maybe they're getting 75 cents or 80 cents.
Right.
If they're seeing a Medicaid patient, they're probably getting a quarter or less.
Right.
So what traditionally has happened is as Medicaid budgets have been strained at the state level, they've compressed down and they essentially pay providers less. And the way that they deal with this is they crunch down on providers every year. So what happens? Predictably, providers say, "I'm not going to see Medicaid patients anymore," and then you end up with a real supply problem on healthcare
Right.
in the Medicaid program. So there are other things states will do, like they'll restrict access to certain prescription drugs they think are too expensive, or certain therapies they think are too expensive. But regardless, what it results in is it results in some form of rationing of care. We don't
Hmm.
call it rationing because that's not popular in America, but that's
Right.
what it is, right? Care is rationed because the supply of healthcare is constrained. And that's fundamentally what happens. And that's the only way that the math works when it comes to the Medicaid program.
There's something else Sacramento could do, Lanhee. They could write to Washington saying, please send us money.
Well, and Washington sends California a lot of money.
Right.
You know,
Send it, but they can say, send us more.
I mean, one of the deals with the Affordable Care Act was that the population that got health care through the Medicaid expansion contained within Obamacare,
Right.
that population gets reimbursed at over 90% of the cost the state puts out. So the
Right.
state's putting out a very small percentage of reimbursement for that population. The traditional population, which is a little bit cheaper to cover because it's primarily kids, and kids tend to be cheaper to cover, that population, you know, they're probably getting, I don't know, somewhere around 60 cents, maybe 50, between 50 and 60 cents from the federal government for every dollar they spend. So, yeah, I mean, the feds could send more, but the feds are fiscally constrained as well. So the notion that they can look to Washington is kind of ludicrous, A, because Washington's already sending plenty of money. And if they were going to send more, every state would want more, and we wouldn't have enough money to pay for everything else.
Well, the reality of Republican Congress is going to send California $3 billion because California underestimated the number of undocumented who signed up for Medicaid. Yeah, just not going to happen.
Pretty unlikely.
Not happen. Robert F. Kennedy Jr. Do you know him? Have you met him?
Yeah, I mean, look, I think he is a very different model of a health secretary. And I've known him.
I'm glad you mentioned that. I went back and actually looked up. So if you go back to the history of HHS and then HEW before that, you're talking about 70 years of secretaries. There are about 26 of them, I think. There's nothing close to Robert F. Kennedy Jr. in
Yeah,
that list.
I mean, you know, and I was gonna say I've known a number of HHS secretaries pretty well. I served one under one, and so you know, it's a different model, but as it's a different kind of presidency, it's a different kind of administration. And if you look at the work they're doing, for example, to consolidate some elements of the agency, I
Yeah,
think some of that work is overdue. I do think some of that consolidation is good. Some will be disruptive. There's no question about that. But overall, it's a very different way of understanding the role of the health secretary. I'll give you one example, which is the focus on food and on the
right.
impact of food on our health and our ability to remain healthy as a society. That is something that previous secretaries haven't spent as much time on, quite frankly, as RFK has and will. And so, as I see it, I don't want to argue whether it's good or bad. I'll just say that it's a very different model, and
Mhm.
and this administration is going to do business very differently, whether it's in economic policy or certainly in healthcare policy.
Right. He has it's an enormous challenge. I mean, it's an enormous bureaucracy he's taking
That's
over.
80,000 people,
Right.
right? It's big, big agency. A lot of responsibilities, and a lot of different things going on, some of which is very critical, some of which, we'll see. But he's made the decision that a lot of that needs to be consolidated down, and he may be right, he may be wrong, but time will tell.
Right. What do you think he's going to do on vaccines?
I don't know. There's sort of two very different ways of thinking coming out of it. I mean, there certainly he has expressed a measure of skepticism. I think the way the agency has approached it is in a much more skeptical fashion than previous administrations. In some ways, the activity of vaccine approval and drug approval is moving as has been the case in previous administrations. In others, I think there is a little more skepticism. And so, how much of that works its way into what actually gets approved, what actually the marketplace tolerates, what people are going to do, again, time will tell. But his attitude and his mindset is we want the science to be rigorous, and we want to make sure that we're making decisions based on that. And for some people, that's going to result in outcomes that they don't like. And I think they're willing to accept the blowback for that.
It would seem to me he's benefited from having Elon Musk in Washington as well. Musk gets so much attention that there's been relatively less attention so far directed toward RFK. Now he's been in the news from time to time, but
Yeah.
boy, it's Doge, Doge, Doge every day.
Yeah.
So disruptors going into town. So you've run for office. You've thought about serving in public office. Your thoughts on disruptors getting involved in federal and state government? For example, look at California. Could California benefit from a Doge and someone like Musk coming into Sacramento and
Uh, I mean,
after things?
look, I think California could definitely benefit from someone taking a very critical look at how we're spending money. I mean, that's one of the
Right.
reasons I ran for controller was because I felt that there wasn't someone taking a very critical eye toward it wasn't so much, I mean, yes, we spent a lot of money, but it
Right.
wasn't so much the amount, although that's an issue, it was how effective that spend was, and that's what bothered me. It felt like when you talk to policymakers in Sacramento and you'd say like, hey, are we solving this problem? They'd be like, yeah, of course, look at all this money we're spending. And they never stopped to ask the question like, is the money actually working? And so to me, it's about, I want to divorce it from the Doge conversation for a moment because I think Doge has become very polarized. I think the
Mhm.
reality is that we haven't spent a ton of time really getting into the nitty-gritty of is our spending really going to what we say it's going to, and is it effective in the way that it needs to be effective to solve the problems Californians have?
Right.
And so we need some form of examination in California. We have a bunch of different officials who could be engaging in that activity already, but politically it doesn't serve their interest to, so they don't. The controller who did get elected, I don't think she particularly cares. My sense is she hasn't really spent much time thinking about these issues either. Maybe busy trying to figure out what job she wants next. And that's the reality of politics in Sacramento.
Well, she's never in the news, but with Musk, it's interesting because he comes from a tech culture, and tech does things in terms of hours, days, weeks, sometimes months. But government, as we know, doesn't do things as a month. Government does things in terms of years. So it's fascinating to me to watch that clash of the Musk culture versus the federal culture.
Yeah, but I think that's part of the issue with government, right? Is that it does move so slowly. It's tough for change to happen sometimes because once you try to change something, it's no longer current. And this is part of the debate we can have about Trump and Musk and what they're doing is, whether they're doing is good or bad. I think the reality is that you're not going to be able to make significant change by moving incrementally. And they're moving quickly and they're going to make mistakes. They have made mistakes, I think. But there's also ways in which those changes wouldn't happen if they didn't move in the manner in which they've moved. So it's a little bit of a tough dichotomy because on the one hand, you are going to make mistakes and there are going to be things that are going to happen that people don't like. But you wouldn't have had the changes people did like if you didn't have the ones they didn't. So, this is the problem.
Okay. So tell me what the healthcare policy working group is coming up.
Well, we just had a great conference about a month ago where we brought, some of the leading thinkers in healthcare policy to the Hoover Institution and sat for 2 days and talked about all these different issues we talked about, Bill, the tax code and about private health insurance, about Medicare, Medicaid, drug approval, really important topics in healthcare. And our goal is to continue writing and researching and
Mhm.
connecting the academic and analytical work that's being done in healthcare with policymakers in a way that they can understand and use and deploy to actually make better public policy. And that's really the secret sauce of what we're doing with the working group is providing that linkage between the research and the thinking and action. Because I think a lot of times in healthcare, and this is true in a lot of policy areas, you have a lot of good thinking and research and stuff that's being written, and then you have the policymakers, and it's not clear that that connection is always made. And so we want to make sure that we're drawing the connection and providing that connective tissue and helping people understand, helping policymakers understand in particular how it is that the research that's being done about the healthcare system can impact how they do their work. And we feel very strongly that there's a need for that, and we're excited about the opportunity.
Right. And finally, we've talked a lot about healthcare reform at the federal level. We haven't talked much about the states, though. So, is there anything worth looking at in terms of Austin, Tallahassee, innovative states?
A lot. I mean, look, I think, Bill, so much of the important work of healthcare reform, because the federal government is so intractable in a lot of ways,
Right.
is going to happen at the state level. And whether that's innovative programs to cover more people, ways of reducing cost, increasing transparency, bringing together the public and private sector. So many states have done interesting work. Georgia is doing a ton of interesting work. They have a program called Georgia Access that's designed to make a healthier marketplace so that people can get access to healthcare plans that make sense for them. You look at a state like Alaska that's done a lot of work at figuring out how they can make insurance more affordable for populations who are tough to insure. You look at other states like Idaho and Utah Texas, as you mentioned, Florida, all these states are doing some really interesting work across a whole host of healthcare areas. And by the way, not all red states. You've got some blue states that are experimenting with different healthcare plans. Some of it I agree with, some of it I don't. But that's the beauty of a federalist system, is that you have states that can experiment, and the good ideas succeed and the bad ideas fail, and that's what our system is for.
Okay, final note. Any conversation with Lanhee Chen has to include his incredible love for the Los Angeles Dodgers. And he is, as long as I've known him, he's been a Dodgers fan. He has not jumped on the bandwagon. I'm confused, Lanhee. I should hate the Dodgers. They're from Los Angeles. You got to hate Los Angeles. They've spent a lot of money to bring in a lot of talent, and they win. They're 8-0 as we go into this podcast right now. But my God, it's a fun team to watch. I'm having a hard time disliking them.
Yeah, it's very entertaining, and the ways in which they're winning games. I mean, the last couple games they've won by coming from behind. The most recent game was a walk-off home run by Shohei Ohtani, and it is a fun team to watch. There's so many personalities and fundamentally, good people led by a strong manager who I think is a good guy at core, Dave Roberts. So it's a great team. It's the kind of golden age of Dodger baseball. I'm really excited to get to share it with my family and my friends, and we'll see how long it lasts, right? No dynasty lasts forever. It's not really a dynasty yet. They've won one championship, but hopefully it can be a dynasty, and it's a great time to be a Dodger fan for sure.
Well, like you, I'm always getting asked questions by reporters. Point me to something in California that works, and I have to point them to the Dodgers because it's just an incredible business model they produced.
Yeah, no, you're right. It is, and it's always fun to watch for those of us who are fans, and I'm glad to hear it's fun to watch for people who aren't fans as well.
Yeah. Okay. Lonnie, enjoyed the conversation. Thanks for doing this.
Thanks, Bill.
You've been listening to Matters of Policy and Politics, a Hoover Institution podcast devoted to governance, balance, and power here in America and around the globe. If you've been enjoying this podcast, please don't forget to rate, review, and subscribe to our show. And if you wouldn't mind, spread the word, tell your friends about us. Lanhee Chen has an X account. His X account is at Lanhee Chen. That is spelled Lanheechen. The Hoover Institution is also on X. Our X handle is at HooverInst. That's HOOVERINST. We also have Facebook and Instagram feeds in case you're curious. Speaking of the Hoover Institution, I recommend you go there and sign up for the Daily Report, which keeps you updated on what Lanhee and his Hoover colleagues are up to. That's emailed to your inbox weekday afternoons. And we'll be back soon with a new installment of Matters of Policy and Politics. Until then, take care. Thanks for listening, and we will see you soon. Bye-bye.
This podcast is a production of the Hoover Institution, where we generate and promote ideas advancing freedom. For more information about our work, to hear more of our podcasts, or view our video content, please visit hoover.org.